of the chest compressor.
As the team leader asks me to commence chest compressions, I do so. Note that at each time the team leader gives me an instruction, such as start chest compressions, I confirm that I've heard the instructions by responding, "Okay, I will start chest compressions," and I look to check that the team leader has heard me. This is the closing loop in closed loop communication. I perform 200 high-quality chest compressions as specified in the ACLS manual. I count these compressions from 0 to 150 quietly under my breath, but after 150, I count louder so that the entire team can hear me. This tells them that I'm 30 seconds away from a break in chest compressions so that they can prepare themselves for what needs to be done in the break. At 200, I stop compressions. I step away from the table in case an electrical shock needs to be delivered. During this time, I am counting down from 10. 10, 9, 8, 7, 6, etc., so that the rest of the team can expedite the crucial tasks which must be done during the break. Chest compressions done well are exhausting, so I need a break. I position myself at the head of the table to take over the role of the Airway Guy.
Roles and responsibilities of the airway person.
As the Airway Guy, I ventilate the patient with 100% oxygen, giving tidal volumes of approximately 500 mLs, 8 to 10 times per minute, being careful not to get carried away in hyperventilating the patient. I am close to the patient's carotid, so during the break I gently feel for a carotid pulse and announce my findings as quickly as I can to the team leader. After this, I step away from the patient in case an electrical shock is imminent. Bagged valve mask ventilation is occasionally challenging, but usually it is not too strenuous if the patient is already intubated. Therefore, after stepping away from the table, I prepare to take over the role of chest compressor. If the patient's pulse returns and his vitals stabilize, I change the ventilation parameters to 10 to 12 times per minute, again, being careful not to hyperventilate the patient. If this resuscitation is not quickly successful to maximize our chances of success, I will commence end-tidal carbon dioxide monitoring, if it is not already in progress, and a value less than 10 millimeters of mercury usually means the chest compressions are inadequate. If the airway is not being managed by an experienced anesthesia provider, there is the possibility that the end-tidal CO2 is low because of a problem with inadequate ventilation. Ensure you have an open airway.
Roles and responsibilities of the defibrillator.
D1, defibrillator. My job is to run to retrieve a Zoll multifunction defibrillator as fast as possible, if there is not one in the room. When I return with the Zoll, my first job is to announce its arrival to the team leader. There are very few things that are important enough to interrupt high-quality chest compressions, but if the resting rhythm is known to be shockable, I will interrupt chest compression because the priority is rapid delivery of a shock. I must rapidly apply adhesive defibrillation pads over the cardiac apex and the right parasternal region. Then I select a defibrillation mode, select energy of at least 120 joules. Note that all modern defibrillators are biphasic devices. I press charge, and when charging is complete, I shout, "Stand back." I check that the scene is well clear and deliver the shock. It is essential that we do not wait to see the result of the shock on the patient's rhythm, nor do we check a pulse, but the chest compressor continues immediately with another cycle of 200 chest compressions. During the next break in compressions, I will select an energy level of 200 joules. At this point, several important points must be made. In order to pace the patient, select pacing mode and select rate to approximately 80 per minute, and the number of multi-amps to 60 milliamps. If pacing fails, it is almost always because the Zoll has no idea what the rhythm is, unless the Zoll 3-lead EKG is also attached. This is a common error because the patient may be connected the cardiac monitor, which lives in that room, but Zoll pacing requires both the Zoll pacing pads, which are the same as the defibrillation pads, and the Zoll EKG electrodes applied concurrently for pacing to be successful. If this arrest occurs outside of the operating room and the patient is not attached to a cardiac monitor at the time of the arrest, we will assume that it is an arrest in ventricular fibrillation and shock the patient blindly. Immediately after this, and while chest compressions are in progress, I will attach an EKG electrode to the left and right shoulders and a third one close to the left hip and commence 3-lead EKG monitoring as quickly as possible.
Some important notes on the use of the Zoll defibrillator. When selecting defibrillation mode, always check that the sync option is not illuminated, otherwise the shock will not be delivered. Recall that sync mode may be a default setting and may repeatedly reactivate after each and every shot. The drug delivery person.
My first job is to prepare 1 milligram of epinephrine because I know this is almost certainly going to be required very soon. I check my drug cart, and if I do not have amiodarone immediately available, I send a runner to the pharmacy to get some. Next, I will prepare 2 or more 1 milligram doses of epinephrine. Next, or as soon as it arrives, I will prepare an IV dose and 300 milligrams of amiodarone. Amiodarone 300 milligrams are administered only once in an arrest scenario, so I do not need to prepare more than 1 syringe of each of these. If time allows, however, I will then prepare multiple doses of epinephrine. After administering any drug in resuscitation, don't forget to flush the drug in with 20 milliliters of saline and then raise the arm for 10 seconds. Note that each time the team leader tells me to administer a drug, I confirm that I have heard the instruction by repeating the command. Then, when I administer the drug, such as epinephrine, I say out loud, "Okay, 1 milligram of epinephrine is in," and I look to check that the team leader has heard me. Again, this is closing the loop in closed loop communication. Then I turn towards the documenter to make sure he or she has heard all of this and is documenting the drug's administration.
From behind the scenes, I see, I hear, and I document everything. I start by documenting the time of when the resuscitation starts, of each defibrillation, each drug given, the prevailing rhythms, return to a stable rhythm, the time the patient leaves to go to the ICU, or that time when the code is called to a halt. From my point of view, this is not primarily a medical legal exercise. Its true value is in the analysis and the discussion of the team performance and the debriefing. Remember, if we do not learn from the mistakes of history, we are ultimately doomed to repeat them. The medical detective. Again, this is a quiet role, taking place mostly behind the scenes, but I can make the difference between success and failure. I quickly review the patient's main diagnoses, their past medical history, and I look for a cause for this arrest. I look for do not resuscitate orders, for advance directives, and possible diagnoses of malignancy. And all the time we're thinking about the appropriateness of performing this resuscitation. My main tools for information gathering are the patient's chart, the computer database records, the possibility of contact with any of his doctors who may be off-site, or his nurse may have very important information to offer. I will interview the family if necessary. I will ascertain the patient's wishes as best I can, and I clearly want to distinguish the patient's wishes from the family's wishes. When I have made every effort, I report my findings to the team leader, even if all my findings are negative. The end.